I am Dr. Vishwaraj Tadakal. I am MBBS MD General Medicine. Practicing at Tadakal Specialty Clinic, I specialize in diabetes, hypertension, along with gastroesophageal reflux disorders. Today, we'll be sharing a small talk on relating to GERD, that stands for gastroesophageal reflux diseases. Let us begin with a basic definition of what does GERD means, what is GERD, how do we look into it, and the basic pathophysiology behind a gastroesophageal reflux disorder. So, what is a GERD? Here you can see an anatomical radiographic landmarks of the lower esophageal sphincter, right? Here you can see esophagus connected to the stomach, where there is a lower esophageal sphincter that allows and closes upon receiving food or liquid. This sphincter is very important for the understanding the anatomy and the physiology behind our GERD. So the GERD is a normal physiological phenomenon experienced intermittently by most people, particularly after a meal. The GERD occurs when the amount of gastric juice that refluxes into the esophagus exceeds the normal limit, causing symptoms with or without associated with the esophageal mucosal injury. The American College of Gastroenterology, the symptoms or mucosal damage which is produced by abnormal reflux of gastric contents into the esophagus, which are often chronic and relapsing. We may see many complications of GERD in the patients who lack a typical symptoms. Normal physiologic versus pathologic GERD when we see, in physiologic GERD, we see postprandial, which is short-lived, which is asymptomatic, and there are no nocturnal symptoms. In pathological GERD, there are symptoms, there are mucosal injury, and there are nocturnal symptoms. So, what happens is next, because of the pathologic causes, there is something called as esophagitis. This esophagitis is rarely caused by agents other than the reflux. The acute esophagitis may be caused by infective agents, that is bacterial infection, which is very rare, but fungal infections like Candida albicans is also common. Viral infections of the esophagus, particularly herpes simplex, cytomegalovirus, are seen in patients with immunocompromised status, that is mainly AIDS patient. Or we can see physical agents, that is irradiation or ingestion of any caustic agents. So what is the epidemiology of this? About 44% of the population have heartburn at least once a month. 14% of Indians have symptoms weekly and 7% have symptoms daily. So the GERD pathophysiology is only because of an abnormal lower esophageal sphincter, or it is an increased abdominal pressure. In the GERD pathophysiology, what we are seeing is an abnormal lower esophageal sphincter that leads to functional, that is frequent transient lower esophageal sphincter relaxation, mechanical, that is hypotensive lower esophageal sphincter, food such as alcohol, coffee and smoking. Next, we have medications like calcium channel blockers and location that might be prone to an hiatal hernia. And the next common cause or the pathophysiology behind GERD is an increased abdominal pressure like obesity, pregnancy, and increased gastric volume. The primary barrier to this esophageal reflux is the lower LES, that is lower esophageal sphincter. LES normal works in conjunction with the diaphragm. If this barrier is disrupted and acid goes from stomach into the esophagus, what we have is nothing but a GERD. Now, what are the clinical manifestations of this GERD? The most common symptoms are heartburn, retrosternal burning discomfort, regurgitation, effortless return of gastric contents from the pharynx without nausea, retching, or abdominal contractions. Atypical symptoms may be like coughing, chest pain, and wheezing. The diagnostic evaluation of the classic symptoms of heartburn and regurgitation, if exist in the absence of alarm symptoms, the diagnosis of GERD can be made clinically and the treatment can be initiated. What is esophagogastroduodenoscopy? Here, what we call it as an endoscopy is inserted and seen to exactly what is happening in the gastric mucosa. Here, this is done in patients with alarming signs and symptoms, or those who fail a medication trial, or those who require long-term treatment. So, what should be the pH monitoring? There is a test called as something called as 24-hour pH monitoring. It is an accepted standard for establishing or excluding the presence of GERD for those patients who do not have mucosal changes. A transnasal catheter or a wireless capsule-shaped device is inserted and the 24-hour pH is seen. So what are the complications of this GERD? Here the patient may suffer from erosive esophagitis, stricture, or something called as Barrett's esophagus. The complications, that is erosive esophagitis, is mainly responsible for 40 to 60% of GERD symptoms. Severity of these symptoms often fail to match the severity of erosive esophagitis. The next complication what we see is esophageal stricture. Result of healing of esophageal stricture will lead to erosive esophagitis will lead to esophageal stricture. This may require dilatation. A Barrett's esophagus is an intestinal metaplasia of the esophagus, the associated with development of adenocarcinoma. The Barrett's esophagus is nothing but the acid damages the lining of the esophagus and causes chronic esophagitis. The damaged area heals in a metaplastic process and abnormal columnar cell which replaces the normal squamous cells. This specialized intestinal metaplasia can progress to dysplasia and then adenocarcinoma. The mainstay treatment for all of this is H2 receptor blockers, proton pump inhibitors. The summary, if you can tell, in a GRD is GRD that can lead to Barrett's esophagus. Barrett's esophagus will lead to high-grade dysplasia and can lead to adenocarcinoma. The most common malignant tumors of esophagus are squamous carcinoma, adenocarcinoma. The prognosis of both type of this carcinoma is actually poor. Hence, the main pathogenesis of a GRD is nothing but an impaired lower esophageal sphincter, hypersecretion of acid, decreased acid clearance resulting from an impaired peristalsis or abnormal saliva, delayed gastric emptying, or duodenogastric reflux of the bile salt and pancreatic enzymes. So this is how our GRD occurs. Okay. Now what we'll do is we'll also go with a slight discussion about what is LERD and GERD. So that also a few minutes I would like to speak upon it. So there was one study which was called as the laryngopharyngeal reflex. Okay. As we all were dealing to completely now with gastroesophageal reflux disease, now I would like to also throw upon a topic called as laryngopharyngeal reflux. Okay. As you all know, GERD is a condition where there is a repeated black flow of the acid from stomach into the esophagus, which is also called as the food pipe. Whereas the laryngopharyngeal reflux or LPR is a condition when the acid travels up into the throat and the voice box. LPR is less common type of acid reflux and you might not experience heartburn or indigestion with LPR, which are common if you have a GERD. GERD more often affects the lower part of the food pipe close to the chest, while the LPR reaches higher up into your throat. Some people may have both LPR and GERD, but may have only symptoms of LPR. The causes for both GERD and LPR can be due to physiological, physical, and lifestyle factors. The most common physical cause is the presence of a weak muscles in the lower end of the food pipe. When the gastric juices travel from your stomach into your food pipe, then into your throat, the sphincter, which are actually muscle walls, close your food pipe at both the ends. The top wall separates your food pipe from the throat and the bottom one separates your food pipe from your stomach. The acid reflux when the lower muscle wall is weakened allows the stomach juice to flow back into your food pipe. The LPR occurs when the upper muscle wall also weakens and the acid present in your food flows very high into your throat. So this is called as LPR, that is laryngopharyngeal reflux. The other physical factors which are responsible for these conditions are hiatal hernia, abnormal spasms, or low emptying of the stomach. Many factors can affect these two walls and cause them to relax, like some medication, certain fruits, drinks like chocolate, alcohol, and also can be triggered during pregnancy as well. Eating habits such as overeating, eating late, lying down after meals, burping, and singing may also cause your laryngopharyngeal reflex. The cause of GERD and LPR in infants and children may be because of the growth and developmental issues. The symptoms of GERD and LPR may overlap. Sometimes the adult patients may experience symptoms related either to GERD or LPR like heartburn, causing a surged black flow of the stomach. The frequent throat cleaning or coughing or production of excessive mucus, bitter taste in mouth, burning sensation, soreness or feeling of lump in the throat. And the other symptoms include change in voice, difficulty swallowing, drainage down the back of nose, choking episodes that might wake you up night, and difficulty in the breathing. So while GERD and LPR can happen together, some people have only symptoms associated with one of the condition. If you experience symptoms twice a week or more, I think you should see a doctor for help. So this was in brief regarding what is a GERD, what is an LPR, and what are the pathophysiology behind these two disorders. Okay. Now, before concluding our session, I would like to share some of the tips, the drugs which are available for the medical community and how a patient can try to alleviate the symptoms by including a healthy lifestyle and including a healthy diet. So coming to the pharmacological treatments, what we have for GERD and LPR, we have the most common and the old drug, that is your PPI, that is proton pump inhibitors, which are commonly used OTC drugs and commonly prescribed drugs that can help you with your gastroesophageal reflux disorder. Basically, what this PPI does is the PPI reduces your hypersecretion of the acid, thus reducing the quantity of the acid secretion which might damage your esophageal cells, thus reducing the chances of you are having a erosive esophagitis or erosive stricture. Next common drugs what we can use is your simple antacid liquids like aluminum hydroxide, your sodium alginate, your oxetane containing liquids. Okay, what does this do is once again they make sure that the whatever extra acidic content which is there in your stomach, it will neutralize it and thus reducing your chances of heartburn. The newer drugs, we have even PCAB right now called as vonoprazan and other drugs which act again at the acid secreting metabolism. Thus, in case we are reducing the total acid which is being produced in your gastric mucosa. The other drugs which can be used in GERD or LPR is drugs which increases your gastrointestinal motility and pushes the food forward, like your prokinetic agents which you commonly use like etopride, levosulpiride, etc. These drugs can also be safely used to treat GERD. The next common thing what we can do is, if even with all of this the GERD is not being addressed, is go to your nearest physician or gastroenterologist, get an endoscopy done, see how is your LES, see if you have a gastric mucosal ulcer, etc. And if anything can be done, do you require a surgery or a lifestyle will be better. Now you can ask me what are the best lifestyle changes that anyone can bring to prevent this GERD. The best lifestyle changes that anyone can bring is first to stop alcohol, smoking, and your limiting the eating habits. Do not eat excessive spicy masala foods. Make sure whenever you're having food, have it in little quantities. You can have food frequently, but the quantity should be minimal. Make sure you exercise 20 to 30 minutes per day. Then avoid caffeine, have minimum 8 to 10 hours of sleep. And then this is your simple treatment for GERD in your, including your lifestyle. Okay. First is quit smoking, quit alcohol, limit excessive acidic foods, limit caffeine, have 8 hours of sleep, 20 minutes of walking per day, have small meals but frequently. This is how a whole in whole a GERD and LPR is addressed, and this is the drugs and the lifestyle changes that we can do to address these issues. Thank you.